Hello and welcome back to the Envirohealth podcast. I'm your host today, Emily Muller, and I got to sit down with Professor Ed Gregg and talk to him about his research in diabetes and cardiovascular disease epidemiology. So welcome, Ed. Thank you so much for being with us.
Thank you, Emily. It's a treat to be here.
So usually we begin with this question, what are you looking forward to?
What am I looking forward to? Well, I've been here at Imperial about 2.5 years, and I have found that it takes 2 years to learn your way around and get your feet under you. And I'm just really excited now because we have big new projects underway that are going to allow me to, I think, tackle the diabetes problem in new ways for me at least, and hopefully new ways and important ways for other people as well.
New ways as in you're looking to the UK as opposed to your sort of previous role in the US?
I think both. I think that, so my role in the US was to guide surveillance, diabetes surveillance, to influence policies for prevention, right? But US was just sort of a microcosm for what's happening in the whole world for diabetes, right? Mm-hmm. At one point in time, in the US, we thought we were the center of the problem. And as it turns out, the US is actually probably one of the countries that's probably better than average now. So this is a global problem. So all the problems that we were tackling in the US in terms of understanding the dynamics of the diabetes epidemic, what's happening to incidence, to complications and morbidity, and how it's affecting all subgroups of the population and what to do about it, all those things are relevant all around the world, except that ultimately public health is such a context-specific problem that you have to bring that aspect in. So one of the things that you asked me what I was looking forward to, I'm excited about the mandate and the ability to look beyond the U.S. and actually think about this as a global problem. So.
Wow, that sounds really exciting. I would like to know more about how you sort of found yourself in this field of research, and generally actually, first of all, how did you get into science? And then how did you particularly find yourself in diabetes?
Wow, good question. So how did I get into public health? Well, if you go back 25 years or so, I at one point found myself working with a master's degree in exercise physiology and cardiac rehabilitation, and found myself working in a diabetes treatment center. And as I worked there, I started reading the literature and becoming actually more interested in what was happening at the population level around the world. And that was what really sort of inspired me as I thought creatively about the problem. And then that led me to go get a PhD in epidemiology. One thing led to another. I got a position as a staff epidemiologist at the Centers for Disease Control in the US in Atlanta, Georgia, where I started working basically in the diabetes problem for the U.S., and I spent 10 years as an epidemiologist. But gradually I found that for me, and I think is the case in general, is that epidemiology is sort of a core science for public health. So I found myself drifting more into how we use our science to affect health policy and prevention, how it integrates with economics, how it integrates with behavior and everything that goes along with it. So, and then after 20 years at CDC, I found myself, thankfully, right here in London.
I always find it really interesting with people's sort of career trajectories, how sometimes it can be a sort of chance encounter, and other times, somebody really has this ambition goal and sort of heads towards it at every single opportunity. Would you say that for you, there's been moments where it's really like it could have gone one of two or three or four or five ways, or have you very much sort of had your eye on where you wanted to go?
I would say, for better or for worse, I've been one of those people who've sort of jumped at the chances and opportunities that come in front of me, but I haven't thought that consciously ahead more than a couple of years at a time. So, when I remember a year after I'd finished my PhD, one of my colleagues who I'd worked with when I was a graduate student had just gone to CDC, and he was looking to bring people into the unit he was forming, and he gave me a call. And that was something I had never thought about. I was just really lucky to be in the right place at the right time. And I jumped at that, even though it meant at that point, leaving what has been a new academic job. And then a number of years later, I would say that the same thing happened again when I came to Imperial. I had been thinking for a while that at some point after working at CDC, I would try to go and find a great spot in an academic setting, but I didn't really have an idea what that was. And then I had colleagues here that helped to make that happen for me to come to here. So just really a couple times in my journey that I've had nice opportunities put in front of me and I've jumped at them.
So given your work at CDC and sort of this really, complex public health policy prevention, what would you say is some of the most challenging and rewarding aspects of, being in this multidisciplinary arena where you have to really bridge together, like you were saying, the economics of it all, the health elements of it all? What would you say, if for somebody that wanted to step into that sort of role, what would you say are some of the most resilient sort of characteristics you might have to nurture and things you might be able to avoid to just not get into too much heat?
I guess I would say that one of the things is that when you're a graduate student, you're kind of working through this notion that there's this field of study that you're supposed to master, and then you feel this pressure on yourself to achieve this certain level of knowledge and skill. And now I realize, looking back after many years, is that things are changing all around you. You can't possibly, I suppose there are brilliant people that can, but I realized that I couldn't possibly understand and master all the stuff that actually we need to use to advance in science. So we're constantly learning how to apply new areas and integrate them with what we do, and that's I think that's how the most effective people actually really work. They're recognizing that the way we get things done is with other people and through actually skills that we don't have and we may never have, but the key is how we understand how to put them together. And so when I was at CDC and I was realizing, wow, I'm going to have to step beyond epidemiology and understand what health policies and economics is all about. Now I'm in another sort of setting where I'm also having to learn sort of how we apply new methods that are way beyond the things that I was trained in, how we put them to use, how we work with new data systems, how we work with different people. It's a constantly evolving role where we're constantly having to do that.
That's so interesting. Especially when you're saying, you're in a new role where you're having to learn. I think sort of something that I definitely struggle with, and I'm sure many people do, is like continuing to learn, and sometimes when you think, oh, I should already actually know this, like I should be informed in this thing, and sometimes that can actually like prevent you from actually acquiring the information that you need to do. So what would be some of the ways that you've learned to just like continually be a learner?
Well, I guess that for one thing, I think we have these sort of ebbs and flows and waves in our work, right? We have times when maybe we're really, creativity's really moving, we're really energized, and then other times we feel like we're in a lull. And maybe that's partly because of the things that are being the demands on us, right? And that we have those waves going all the time. And I think that in one sense it's okay to accept that, and that's sort of normal, that you can't just be going full steam all the time, and that there's sort of periods of rest that allow you to recharge and actually kind of push yourself further. But I think that probably the most important thing is really kind of recognizing that well, at least for me, the reason we choose these sorts of a field like this is because we can continue to learn through an entire career in life. And I think it would actually be pretty boring if we got to the point where we had figured out how to do everything and then we're just doing it. We have, relatively speaking, some periods of time like that when we're getting in sort of more of a routine. But I guess I've kind of feel like if we find ourselves in that for too long, then we should be asking ourselves what we're doing.
Okay, and in this sort of similar vein of advice, what are some of the best advice that you've received?
Well, okay, let me think about this. Going back a ways, I remember some of the earliest advice was never give a rough draft to a group of experts. But it turns out that over time, so I still apply that to some degree, right? But after a while, if you take that to an absolute, then you don't get anything done, right? So I don't believe in perfectionism. I think that perfectionism is sort of it ultimately binds us up if we adhere to perfectionism too long. So that's a bit of a digression.
It's a way not to meet your deadlines.
That's right. There's some funny and cynical advice I've gotten, but I guess that probably the advice, I wouldn't say this is advice, but the models that I've had, or not the idols, but the people I've really admired that have affected me, are people that are not afraid to fail with what they do. They can handle taking some lumps now and then, and in fact, they actually do fail. You know, if you were to sort of quantify things and look at if you could break up the things that they do and try to do into numbers, you would see there's a proportion of things that go great and other things don't go so well. But in the end, they have far more of an impact on what they do in their work and on people around them by taking that attitude that, well, we're always going to do our best, but you're going to fail now and then. That's okay.
At least even give it a shot or many shots.
And well, the other thing is I've noticed that sometimes people don't. Never mind. I'm not going to go there.
Should we take it off? Should we take it offline?
I was going to say sometimes people don't. In the end, people don't even realize they failed.
I love that. Is that a good thing or is that a bad thing?
You know, it's like when you're on the inside of something and you realize that this colleague of yours who went out on a limb, went for it, and really blew it, right? But the outside world never really knew. And I suppose that it's all about your perception. Maybe if you're looking at the weeds, you have a different interpretation than if you're looking at the big picture. So.
Other people not knowing and them not knowing, slightly different.
Yeah.
Okay, so let's unravel sort of your area of expertise.
Okay.
So in your previous hat, you were deeply involved in the care, prevention, and treatment of diabetes in the US.
Yes.
As an epidemiologist. So essentially, if I can say this, examining trends in population health, scientifically, examining trends in population health to identify and prioritize best policies to prevent and control diabetes. So how many people have diabetes, first of all? What proportion are type 1 and type 2? And what is the difference between these?
I mean, in general, diabetes is either an inadequate production of insulin or its inability to use it efficiently, so it's insulin resistance. And at this point now, about 10% of the adults in the world have diabetes, so it's one of the most common chronic severe conditions that we deal with. That's why it's considered a public health problem. So if you think of about 10% or 1 in 10 adults around the world with this problem, it's a huge problem. Of that population, 95% of them roughly have type 2 diabetes, which is it's a combination of inability to use insulin efficiently and also produce it. About 5% have type 1 diabetes. And it presents a problem, of course, for care, but also diabetes does its damage over time by affecting many different organ systems of the body, and in some countries it's the most costly condition for health systems to deal with. It's an enormous cause of morbidity and mortality, so this is, and at the same time most aspects of it are actually either preventable or manageable, so it's really a classic public health problem.
So as I mentioned, you've been really involved in monitoring the trends in the past 30 years. So I sort of want to take a historic perspective, starting in 1994, when diabetes was deemed an epidemic in the US. What was believed to be the driving factors in the burden of diabetes on population health at that time?
Sure. So interestingly, at about that time, compared to now, prevalence was actually quite low. 4 or 5%, maybe 6 or 7, I can't remember exactly, but it was probably half of what it is now. And it was really seen at that point as a complex clinical problem, right? The main problem that was seen is that people with diabetes had a huge risk of developing complications, and they weren't getting the care that at that time was starting to realize was important, so that if you manage glycemic levels of blood glucose, you manage blood pressure, other risk factors, you can have a big impact on whether people with diabetes go on to. So that was going to develop complications. So that was seen as the problem. It was not at that point, although epidemiology had kind of shown that it was lifestyle was a prominent factor, it had not been established that you can prevent diabetes at that point. So the public health response to diabetes was all up at that point largely about how do you care for the problem. And then it was about 5 or 6 years later that more evidence in the first studies of prevention came about. So then the idea of preventing diabetes through risk factor management, through interventions came about. So then it really became, we started to think about diabetes as a problem with sort of two big pathways where we could try to tackle preventing the problem, but also preventing all the complications or the morbidity that follows. Mm-hmm. But along with that, I think that there's a lot of dynamics, a lot of interesting waves and new aspects of the epidemic itself that have happened since that time that go above and beyond just the increase in prevalence that we've seen.
Great. So, as you mentioned, it's from around 5 or 6 or 7, and we're up to 10. Probably back in 2010, it wasn't so high. So we're seeing this increasing prevalence, but as you just said, there's more nuance, and the picture that you've been painting actually sort of breaks this down into different complications and the distributions across the age group. So some of your work from earlier in this decade, that feels so strange to say, in the New English Journal of Medicine, shows decreasing rates of complications within the diabetic population. So complications, first of all, when we're talking about complications, what are the most typical complications that we see with diabetic patients? Let's just start there.
Sure. So, well, traditionally, they divide complications into macrovascular, or the big blood vessels that affect things like the brain. So we're talking about heart attack, myocardial infarction, stroke, the peripheral vascular disease, basically to the extremities, that in combination with neuropathy, disease of the nerve endings, affects risk for amputation. And then you also have lots of effects on the microvascular, the smaller blood vessels that affect things such as kidneys and influence risk for end-stage kidney disease or need for dialysis or transplantation. And those are the classic problems, but it turns out that diabetes affects other problems too, such as risk for dementia, disability, even cancers. It really has a very broad effect. And when we talk about sort of dynamics and changes of the problem, one of the things that's happened over time is that while public health has done a better and better job of preventing people from dying from cardiovascular diseases, this has basically allowed people to live longer, including people with diabetes. So people live much longer with diabetes than they did just 15 or 20 years ago. Mm-hmm. But it doesn't mean the rate of complications and morbidity is necessarily slowing at the same rate. In fact, for a lot of those, it's actually the same rate or even an increase. So what we have is essentially people have more time to accumulate problems and potentially. So now multimorbidity is a growing concern for diabetes, is that living longer, more time to accumulate more conditions. That's sort of one process in the epidemiology that's happening. The other is that we've had this generational issues, really if you go back the last couple generations, the young adults were the most obese children at that point in time. Mm-hmm, mm-hmm. And so now we have a growth and an increase in type 2 diabetes mm-hmm. in youth. Now, traditionally, the median age of development of type 2 diabetes is in the 50s, right? But now we have an increasing, many more, the prevalence and incidence of type 2 diabetes in people in their 20s and 30s and 40s is much greater. And so you have a situation where with a condition that does its damage over time, and you start the clock so early in life, mm-hmm. then you have another way that basically this wide range of complications can form in a population. So sort of two different ways that we're having this.
It's sort of mind-blowing to me, like from the perspective of just biological organisms, that this is just insulin at the root of it. And then, cascading down is just this plethora of complications. And I can see why it's so important to sort of address. So you mentioned people living for longer. What other treatments in care and risk factor management have been either increasing lifespan or reducing the risk of complications?
Sure. So as much as I've described diabetes as being a huge global public health problem, it's actually been a story of success in a lot of ways too. So there's been successes and failures. And I mean, the successes are that actually the rates of complications, if you compare it to 1995, are half what they were at that point. So they really decreased overall. And the reasoning for it is thought to be due to lots of reasons, actually. That care is improved, okay? So levels of the glycemia, the attention to it, the options for physicians and healthcare systems to manage glycemia, the understanding that controlling blood pressure and cardiovascular risk factors can make such an impact. And all of those things, plus then what happens at level of care after people develop complications is improved. So all of those things have led to general improvements for many complications. And then at the same time, you've also had new evidence about the impact of lifestyle and potentially medications in terms of preventing diabetes itself. So you've had those positive trends happening in general. The problem is that most big problems in public health, maybe like we're seeing now with COVID-19, you can't take your eye off the ball. And so we see resurgence of certain problems, not necessarily across the board. Sometimes it's certain, perhaps, subgroups that drive it, but depending, at least in the U.S., for example, there's been a resurgence in some of the complications after all those big improvements, and over 20 years now there's been a bit of, at least in young adults, that's turned back the other way the last 5 years. We're looking at that in the UK. It doesn't seem to be the case in the UK, but in the UK there does seem to be a slowing of the improvements that happened as well.
Which is maybe sort of the US 5 or 10 years ago.
It could be.
That sort of pattern.
It could be. The UK, fortunately, does not have quite the same levels of diabetes as the US. It's a couple percentage points lower, but the general patterns are the same. And the fact that there are subgroups of the population, vulnerable groups that are at much greater risk, and that any time you look at the average in the population, that can be hiding a lot of variation. And so you see that in the UK as well, and that's sort of part of what we've been doing, or I've been doing since I've come here, is to try to understand to what degree are these trends that we saw in the US, are they playing out in the UK and in other countries of the world.
What sort of patterns have you seen in these subgroups, whether like by race or by spatially, where you're starting to uncover things which an epidemiologist would uncover?
Sure. Well, so some of with diabetes and its complications, there are certain race ethnic groups that definitely have higher risk. In the US, for example, Mexican Americans, African Americans, and Asian Americans as well tend to have higher risk of diabetes than Caucasians do. Now, the risk of complications, though, tend to vary a bit. So African Americans have a higher risk of amputations and renal disease, but Asian Americans do not carry that extra risk. Now, if you look in the UK, what you have is there are many more South Asians. In the UK, there's clearly a high risk of diabetes in South Asians. You see that in the US as well. Mm-hmm. But you don't actually have as good data to study it in the mm-hmm. US as we do here in the UK. So there's big race ethnic differences that affect different aspects of the problem in different ways. But in the US, and I suspect in the UK as well, poverty and aspects in the environment are actually more important. I mean, they certainly interact, and if everything is held equal, yes, those certain race ethnic groups have higher risk. But if you, for example, if you go to the U.S. and you look at the counties and the places where the real diabetes belt is, the driving factor is not race and ethnicity. It's actually poverty and income and aspects of the environment.
So when you say aspects of the environment, is it to do with sort of, physical activity, pollution? Is that also in any way related?
It could be all of it. Well, so the epidemiologic studies tell us it's all that. It's education, it's income, it's physical activity, it's quality of the diet, it's access to healthy foods rather than junk food, and all of that. Which of those factors actually explain why places of high poverty have such higher risk of diabetes isn't totally clear. You could argue as well as a combination of all of that, but unfortunately we haven't really seen interventions and programs that effectively act on that to change it, to then change risk in those communities very well. I think that's sort of one of the big gaps and maybe weaknesses in the science, actually.
Interesting. What are, or what have been, or what could be some really key preventative measures which could either help to curtail, diabetes as a chronic disease, or can target these populations in particular? So, I mean, you were here last year, potentially in August, where we had simultaneously, Eat Out to Help Out and, being reprimanded for obesity simultaneously from the British government, which is, just mixed messaging generally. So I wonder if you've sort of seen an excellent example of this sort of targeted intervention at population or subgroup level.
Good question. I think that diabetes is unfortunately probably not going to be affected by a vaccine, right?
I did read that type 1 diabetes, there's vaccine development for type 1 diabetes.
Well, could be. So that's another avenue that I can't really speak to so well. But I think that when we think about type 2 diabetes, at least as far as we know, there's not going to be a vaccine for it. This is it's a classic chronic or non-communicable disease, and in general they require multiple factors, right? All working together, or at least in the same general direction. So I think that what we really need is probably, it would be nice to see demonstrations of places where you really have a concerted effort with attention to the problem, awareness, and then tackling, and with an effort and a view that it's a multi-tiered problem, okay, over long periods of time. So you need to look both at short horizon, short-term benefit, as well as long horizon. And when we say multi-tiered, it's the idea that this is a problem that some things and some aspects we have to tackle by going to people at the highest risk with treatments and prevention that's available. But then you also at the same time need to view this as a population problem. And that with that, your horizon, your time horizon for having an impact might have to be, you might have to think of it as a 10-year problem as opposed to 1 year. As we, right now with COVID-19, we're hoping that we can be done with this. But I don't think that with diabetes, under any circumstances, would we be thinking that we'd be done with it in a year. So we have to view actually with a longer view of how we can change environment, care for both individuals and population.
So when do you think diabetes will stop being a chronic disease?
I don't see it happening. I think that in the foreseeable future, I think what we are seeing actually is we're starting to see many countries with actually declining incidence, okay? But in those countries with declining incidence, we actually still see that prevalence is just as high, and part of that is a function of decreasing mortality. So I tend to think that our goals with diabetes are to decrease incidence, but our other goals are for that segment of the population that has diabetes, to reduce the morbidity and the complications that go along with that still are still a secondary goal that we've got for people to live long and healthy with the condition.
Okay, so last Thursday when we had scheduled our original interview, apparently was the 100th year anniversary on that very day, on the Thursday, of insulin.
Mm-hmm.
And just like reading a little bit about it, it's super fascinating. It was like patented for $1, so people could have access to this medicine. I suppose, as you were saying now, simultaneously reducing incidence, but also having better quality of life for those people that do have diabetes. Why is insulin medication still so expensive? And is there any way that it can be more accessible? And maybe this ties into another sort of thing that I'm wondering about is, and you've mentioned diabetes is a global chronic disease that needs to be addressed across the world. What are sort of the rates looking like in low and middle income countries, which perhaps access to medicines, that there's a whole different sort of nuance in terms of how much it costs and availability. So is there sort of work going into reducing the costs of insulin?
Yeah, so I have to admit, this is not an area that I know well, except that I can answer your first general question is that when insulin was discovered, it was actually pork and beef insulin was used. And then you've had development, so even insulin itself has benefited, and the application of it has benefited from science to develop a synthetic and now many different other formulations of it. And that's essentially what brings the cost. And at the same time, right now, so while insulin and the application of insulin is improving care, you also have a problem of disparities around the world where you have places where, like you say, cost is a limitation or availability is a big barrier. And that's one of the challenges that's, one of the main global challenges actually right now.
So I read this one article about it sounds like there's these like really extreme cases. This is random. There's these sort of extreme cases where in the States with medical insurance, people literally can't afford to buy their insulin.
I mean, so one thing that's interesting was so that when I worked at CDC, there were political aspects that I couldn't. If I was doing this, I'd be like, oh, geez, I'm sorry, I can't talk about that. In other words.
But you're not working at CDC
especially
anymore.
If I was working for the CDC, I wasn't supposed to trash our healthcare system, right? Which I've got no problem. I mean, this has actually been one of the most. There are a lot of things I like about America, but for a country with the wealth that it has, the fact that have such underinsurance or basically they have such barriers to getting the great health care that exists is absurd. And that's actually one of the nice things here to see is that and yes, there's been improvements in the U.S. in access to health insurance, and the Affordable Care Act or Obamacare improved that. But I can tell you firsthand, it didn't solve it. My 27-year-old artist daughter was uninsured for 2 years past Obamacare because of things that happen. And so that did not solve the problem. So yeah, the U.S. still has a problem that people go uninsured, or they have insurance, but the insurance it's such an inadequate insurance that it doesn't come close to equating what we get here in the UK.
Doesn't that make you almost feel like disheartened in a way? Because, say if the problem is 100 and, all of the effort that you put into like prevention, you can only ever reduce to like, let's say 7, you can only reduce by 70 because there's this fundamental 30 which is built into the structure of the medical system.
Yeah. Fortunately, it's not that high. Well, what you're saying actually makes sense intuitively, but one of the things we learned from the economists is that prevention doesn't always save money, right? You know, and so what it comes down to is if we want good health and good health care, we do have to be willing to pay for it. Now, we want to pay for health that's of good value. We don't want to throw our money away in bad ways. And if we take a long time horizon and that, yes, prevention generally is a good option. But to me, the biggest problem in the U.S. is really a lack of equity. You know, if you've got good insurance, you get great care there.
It's such an interesting business case because on the one hand, prevention is sort of like, what is the potential return of investment for all of those individuals that will not have diabetes and will be participating in the economy, versus what is the potential return on investment if you maintain like a good quality of life, they're contributing to the economy, and you're making money from insulin or from treatment.
Well, so you're hitting on another area that I think the case for prevention of diabetes economically is strong. I mean, it's really, if you over the long term, especially if you look at what diabetes does to the working age population, right? And if you look at the reason why it ends up being a cost effective to prevent it, partly is because of quality of life and what it does to people in the working years of their lives, but it also because diabetes affects so many different complications that bring a huge cost when they occur. So when you reduce end-stage renal disease, stroke, heart attacks, you have a big effect on costs. But the other thing is that the number of medications that people are on with diabetes is huge. I mean, to get optimal care, once you get diagnosed, boom, you're on. I don't know if you have family members, you see this, they get diagnosed and all of a sudden they've got a whole bunch of medications.
Well, then it's a whole different issue in the UK where then you would imagine there should be more focus on prevention, where just the cost to the NHS is magnitudes higher directly to the government.
Well, it is. I mean, this is sort of the arena of economists that I don't feel qualified to comment on, but it's to say that diabetes is a huge economic problem for the UK, just like it is for the US. And the ways that they're going at it, in general, are the same. They're trying to find effective ways to prevent it, and then when people have the problem, to manage efficiently and prevent the complications that follow. And in general, things have been improving, at least on the latter. Not so clear in terms of preventing but I think the efforts that are underway are good. I mean, NHS has a prevention program, an individual targeted program with good availability, better availability, that has enrolled actually as many people as the US has during a shorter period of time. And I think actually that's a really encouraging development. It can't solve the problem by itself. You know, you can't expect just to go to, what it does is it finds the high-risk people, gets them support to prevent them from progressing to diabetes. That probably will not change the trends in incidence by itself without changing the underlying risk factors in the community, but it is an important step.
So this process of finding high risk, how sort of built into kind of like surveillance systems and like now having so much data available? I know in the US there's a lot of it's related to like insurance, health records, and the NHS. It's all part of one big system. So are we harnessing all of this information to sort of have these risk profiles for individuals where you literally then are saying, okay, I've been seeing their progression of various different potential risks or complications. Can we, flag it up and say this person has high risk of diabetes?
I would say yes. I mean, the UK it's been one of the really interesting to me to see how data rich UK is. I mean, compared to the US, a much smaller country, it's actually more data. And part of it is because you have a single payer healthcare system, but I don't think it's just that. The US has strengths in data in other ways. It's got systems of surveys that are fantastic, and they're really available. You know, you can just download the data, right?
Yeah, for sure. The
It's
ACS
actually
surveys.
harder. I found the UK to be more data rich. It can be more cumbersome and complicated to get at it, but partly that's because it's individual health systems data. So
Yeah.
it's actually detailed information. So, you know, the protections are in place to, you know, to take care with that data. So and I think that what you're hitting on, Emily, is sort of what the new epidemiology is for us. It's different from when I studied. We were basically doing surveys, cohorts, and trials. They were sort of three areas, but the idea that health systems data and what we get from our visits of all our, you know, that was just starting, but that was not the core aspect. That was not the core data that we use in epidemiology. And now it is. I think that over time, that's actually going to be the majority of what we use, if it isn't already, depending on which arena of epidemiology you work in. But it's still not easy. You know, it's still not easy. It takes, you know, when you trying to dig into and make good scientific use of these health systems data sets. And when I say that, I think that's NHS data is an example of that. It's a mess. It's really a hard thing to do. And I think that's actually where a lot of the methodologic challenges are in epidemiology right now, logistic and methodologic. And so as people are being trained now, that is their laboratory. The UK's been doing all of that too. Okay, what I'm describing is more of a generational change. So the UK is arguably more of the home for epidemiology than the US. I mean, we think of this
Welcome back.
Yeah, right? So UK does trials, cohorts, and surveys as well. But what has been overlaid on those, if you think of those as sort of those are sort of the laboratories for epidemiology, right? You've had health systems data enter as sort of whole nother arena, right? Now, study design is still important, though. So, and that's actually where part of the challenge is, that you have to overlay study design on that health systems data. If you don't, all you have is just a big mess of
For sure.
of electrons. So.
I just think it's so exciting because it's the possibilities, first of all, across all different diseases, you know, for sort of immediate, just, you know, alert, okay, we need to maybe take this person on a new course of action, but then simultaneously how you can bring it can be brought back to the individual. So continuous blood glucose monitoring, and the idea of people actually being able to, first of all, have internal systems which are monitoring and delivering insulin, but even without that happening automatically all the time, if you can just monitor yourself continuously and have an understanding of this sort of pattern of your blood glucose, and then be able to treat yourself better. But simultaneously, what you mentioned earlier was you said, you know, we've got all these new systems and all this new information, but actually people need a lot of training. So,
well, you've just hit on something that I think is a great analogy. What you've described is the problem for the individual of information processing, right? Really, body's really complex physiologically, and now there are tools that can take this but even continuous blood glucose monitoring is all sorts of information. There's variation there. How do the individual, there's a challenge of using that information to basically reduce their risk of bad outcomes, right? Then you can step back and look at what's happening with big data, the way we're using, and we have all sorts of developing methods, machine learning approaches, agnostic and AI to basically process and apply information, data at much bigger levels than we ever had before. This is all new, at least new to me.
Yeah.
And I think actually one of the most interesting and fascinating challenges right now is how we apply that. And so my early sort of attempts to work with some of those methods are that sometimes we find things that are we don't know how to interpret the data.
Yeah.
You know?
Yeah.
It doesn't mean it's not useful, but it means that we have a learning curve for how to use it, for how to use new methods. And I think that's one of our big challenges going forward.
Definitely. And you even highlighted study design earlier, because a lot of the times, you know, the data experts, they're not thinking in the same way in terms of study design. You know, it's more like, how can I throw everything at something and get something back out? So there's so many different players involved. And I guess this is really related to your role at the Abdul Latif Jameel Institute for Disease and Emerging Analytics, JIDEA, which is pretty exciting from what I've heard about it. I don't know if you want to speak on that role at all.
Sure. So, well, JIDEA, Jameel Institute, is doing all sorts of amazing work around infectious disease responses, about disasters, about humanitarian issues. I'd like to think what I'm bringing to that group is the focus on non-communicable conditions, but in particular, what I think our opportunity there is to understand the intersection better of chronic conditions and infectious conditions. And traditionally, those camps have kind of worked separately. They see themselves as from different causes, different solutions, different methods. But I think actually the COVID-19 pandemic, one of the good things about it is that it has broken that barrier, and that those people like myself who spent years working in chronic conditions and diabetes and obesity and cardiovascular disease and never really got asked to participate in anything around infections, we got brought into it, and partly because this is a problem that, well, in this case, this virus was affecting people with chronic conditions much, much more than people without them. So, plus it was affecting all of us in our lives and society. So, but I think that this has made us realize what was true all along, is that chronic conditions are not isolated from infection. You know, we already knew that, for example, diabetes has is highly related to tuberculosis. There are relationships to many infections in terms of the way, for example, what leads to amputations are infections. It's an interaction with with the chronic and management of the condition. But so I think that with Jameel Institute and with other related efforts, we're going to see more. We have the opportunity to look more at how in different countries and how globally infections exacerbate diabetes and its care, and vice versa. And then similarly, how interventions can make a difference.
And has the rapid mobilization of governments around COVID-19 proved as a good example of how this will be possible? Surveillance, monitoring, nationally and globally, and the communication taking place between various different institutes across the world. Do you think it's kind of solidified your faith in this new avenue that we're taking?
I think it's going to. I don't know if it has yet. I mean, there's been some remarkable things that have happened in terms of how quickly, for example, science responded to COVID-19, how the awareness and attention to epidemiology,
for sure,
and understanding the value of statistics, of descriptive epidemiology. Actually, I don't think we ever would have thought that was the case. You know, I think never would end. But the average, I think the general public is far more tuned into what epidemiology is and what incidence and how this is important, and how surveillance is important, actually, in ways that they never were before. I think that's good. I think there's also going to be demands. I think that the expectations for fast data and for interpretation and action from that data is going to be very different than it was in the past. We used to have this, especially we often would have sort of the life cycle of developing a survey and a project would take years. And even a surveillance-oriented problem around an emerging, I can remember when in the U.S. when I was looking at CDC, and this problem of type 2 diabetes in youth had been identified as an emerging problem. They gave us funds to set up a system to understand what the incidence is and who's at risk and why. And it took several years to put together that. Can you imagine if this was COVID-19 and they said, start monitoring this problem, and they said, well, we'll get some incidence estimates for you in 2024, So the point is that now infectious disease reportable systems are already, I'm being a bit facetious there because they're set up to be responsive and respond to new problems. But I think that what COVID is going to do is it's going to make us, there's going to be a greater expectation for responsiveness across all conditions. So it's not just reportable infectious conditions that are expected to get data that's really useful for application quickly.
That means that there's going to be a lot more funding for any budding epidemiologists across the world. All right, awesome. I would like to thank you so much for joining us and sharing all of your expertise and insights with us. It's been wonderful. Thank you.
Thank you. It's been a treat to be here with you, Emily.